It looks like we have most, it looks like one person may still be connecting to audio here, but we have most everyone connected. So welcome everyone to the last of our 5 weeks of the CAPER webinar series. We have a great lineup, I think, to end the session. I just wanted to see very quickly before the session begins that you will get a follow-up email information about CME credit if you are in need of CME credit. We are also going to be asking for your feedback and an evaluation. In particular, if there are things that you would like to see more of or didn't see this year that we should incorporate into next year's sessions, we really appreciate that feedback. So thank you in advance. With that, I will actually turn it over to our two moderators here, Dr. Cheryl Garepi and Dr. Vic Singh, to introduce our speakers.
Okay, so I guess I'll go first. The title for tonight's session is Special Topics in Recurrent, Acute, and Chronic Pancreatitis. And our first speaker is Emily Perito from UCSF. She is the co-director of the UCSF Pediatric Pancreas Program, and she's going to speak to us about pediatric pancreatitis. You can put your questions in the chat, and we'll do the questions after her talk.
Should I go ahead?
Yep.
Share my screen. Okay. Can you guys see the slides and hear me okay? Great. Okay. Well, thank you for having me today. I'm excited to share with you something that we think a lot about, which is pancreatitis in the pediatric population. I'm going to give a little bit of an overview from acute to chronic and try to talk a little bit about what we see in kids and particularly what may be different than what's seen in adults, anticipating that not everybody here is a pediatric specialist. So we really appreciate your time today. So our objectives are going to be to identify risk factors of and complications of pediatric pancreatitis, and then understand what treatment options we have in pediatric pancreatitis. I'm not going to say a lot about acute pancreatitis, except to just draw your attention to a couple of sets of guidelines that I think are helpful if you do run across it. These are mostly consensus guidelines. We do not have a ton of really evidence-based guidelines. There are not big trials even in terms of management. And the principles are very similar to what we see in adults. Where you're hydrating and managing pain, and we have also become much more liberal with early feeding if kids are otherwise getting better. We think that that also reduces complications and reduces length of stay. So I think this is probably a little more straightforward for this audience. I'm happy to answer questions later if there are any about acute pancreatitis, but mostly just wanted to draw your attention to there are consensus guidelines available if it's something you run into. Then just mention a little bit that, I think pediatric acute pancreatitis tends to be not as at least life-threatening as it is in adults, but they certainly can get severe episodes and have the same complications that you see in adults, which include necrosis. It's much less likely to turn into multi-organ system failure in adults than it is in kids. But it can happen. And I think the kids that are at the highest risk are really the teenagers, especially the overweight and obese teenagers, who really can get quite sick in the same way that adults do. We do see kids with more severe episodes get pancreatic leaks, get pseudocysts, get strictures, and in some cases even have a severe enough episode where they develop exocrine insufficiency or diabetes. It can, just like adults, evolve into chronic pancreatitis if they do have stricturing or really severe damage to their pancreas. So again, most kids get an episode of acute pancreatitis and get better without complications, but particularly those older teenagers, especially who are overweight or obese, that's sort of the most common comorbidity I think that we see, that where they really can get quite a lot sicker. And then, of course, if it comes back, Kids do develop acute recurrent pancreatitis, which, as many of you probably know, requires at least 2 distinct episodes of pancreatitis with complete resolution of pain in between and normalization of amylase or lipase in between. And they can also develop chronic pancreatitis. And we'll talk a little bit about what causes chronic pancreatitis in kids and what we do about it, because this definitely is different, I think, than what you generally see in adults. Despite the experience of many of our kids who have been to the ER many times and been told that kids do not get pancreatitis and definitely don't get chronic pancreatitis because they're not exposed to alcohol or other risk factors, kids do get chronic pancreatitis. Luckily, not a lot of them, but it is, a really burdensome disease for those that do. And a lot of the data that I'll show you today comes from the INSPIRE study group, which now has more than 600 patients enrolled and continues as a prospective cohort study that we are fortunate to be running within the CPDPC, with the NIH and NIDDK funding. In our cohort of kids from 2 generations of INSPIRE, the median age at first pancreatitis attack was about 7 years, but ranges widely. And it's really a painful chronic disease, just like it is in adults, where more than half of kids have constant pain. And it really can lead to sort of pancreatic failure, by which I mean exocrine insufficiency or diabetes, even in childhood. These things are, not happening to all kids with chronic pancreatitis in childhood, but they definitely can develop, and it's something that we're monitoring closely for. This is just to show you where the INSPIRE sites are that we're really enrolling kids from all over the country, as well as outside of the US. And this is the biggest, by far, cohort of kids with acute recurrent and chronic pancreatitis that has ever been followed. And so we've really learned a ton and continue to learn a lot, and are really hoping that we can turn it into also a platform for trials, hopefully, to really improve the treatment options that we have for kids, because those, as an adult, are relatively limited. So what does chronic pancreatitis look like in children? Many of you are probably familiar with these type of images from ERCP. So you can see the scope and then the pancreatic duct. And the upper left corner shows you a relatively normal looking pancreatic duct. It's very small and relatively straight with maybe a little bit of undulation, but you can't see any side branches. In contrast, in kids, even in young kids, this is a 9-year-old on the bottom and a 3.5-year-old on the sort of more to the right. You really can get quite significant changes consistent with chronic pancreatitis. You can see that both of their ducts are quite dilated. They have strictures manifested by filling defects, as well as clubbing and really prominent side branches. So, and these kids both had underlying genetic mutations, which I'll talk a little bit more about, that predispose them to chronic pancreatitis. The phenotype of when these diseases onset and how severe they are is really variable, just as it is in adults. But even the younger kids can really get quite severe changes in their pancreas, as you see here. What causes chronic pancreatitis in kids? So this, again, is prevalence data from the INSPIRE cohort, and just makes the point that a lot of the kids have one or more genetic mutations. These names are probably familiar to you. PRES1 was probably the most common sort of single factor that onsets in kids, but certainly we see a lot of other mutations as well. And then we always think about, other anatomic issues that might predispose to chronic pancreatitis. We see a little bit of autoimmune pancreatitis, either acute recurrent or more of a chronic picture. And we think about medications as well. In terms of what we do to work up and diagnose why kids have acute recurrent or chronic pancreatitis, for most diseases in kids in particular, we usually think of like one cause. There's one thing. that happens, and most kids, you know, otherwise do not have very complicated medical histories. We find in acute recurrent and chronic pancreatitis, there's a very often more than one risk factor. So even if we find one thing, say a SPINK1 mutation or a PRES1 mutation, we tend to sort of do all the rest of the workup to look for anatomic or other contributing factors as well. Because again, I think that often we end up finding sort of more than one risk factor that's contributing. We, at least at our center, we always will do both CF genetic testing as well as a sweat test and a careful history and exam for other manifestations of CF. We have diagnosed a number of kids with CF related disease that did not initially have mutations identified on their genetics. I think this is, you know, particularly in patients that may not be Caucasian or have European ancestry, that the mutations they have related to CF may not be picked up by the routine panels. This has gotten a little bit better over time, but we still see it every once in a while. We send IgG4 for autoimmune pancreatitis, although the sort of type of autoimmune pancreatitis that we think we see more often in kids is often IgG4 negative. So it's not, it helps us if it's positive, which it rarely is, but it doesn't totally rule out an autoimmune pancreatitis picture for us. And then in addition to imaging, when we have kids with acute recurrent and chronic pancreatitis, we're looking fairly early to see if they have any signs yet of endocrine or exocrine insufficiency with just some basic screening and then following that over time. The INSPIRE group has also recently published on imaging findings in children with chronic pancreatitis, and we've really been trying to, as I think the adult, you know, site has been working on too, trying to come up with more standardized protocols for both imaging and reading the images on these kids so that we can make sure we're talking about the same things across centers, no matter where you get your MRI. Usually we're using MRCPs or MRIs to look at this. Almost 20% have duct stricture, ductal stones, you know, definitely can be seen, main duct dilation in about 1/3 of them, and then pancreatic atrophy in about 1/4. So in terms of treatment options, we have some, but not enough, certainly. You know, one of the sort of newer things that I think we've been trying in both the pediatric and adult worlds, or at least thinking about, is for patients that do have CF related disease, thinking about whether a CFTR modulator may help. There's a limited number of cases reported so far in both the pediatric and adult literature. I think there's some concern, and we've seen anecdotally that for some patients it makes pancreatitis worse. I think we really don't have good evidence-based guidelines yet about who this might help and who it doesn't, but it's certainly tempting to see if we could improve at least, you know, output from the pancreas and have less stasis and maybe less pancreatitis episodes for a limited number of patients. In terms of pancreatic enzymes, there's no trials on efficacy in children, but it is something that's used certainly in kids that have exocrine pancreatic insufficiency, and in addition by some other folks in an attempt to try to manage or mitigate symptoms. And again, you know, given the relatively limited number of treatment options we have, I think it's certainly something that we will try to see if it helps with symptoms at all, because we think it's relatively low risk. For nutrition, we really try to encourage age-appropriate balanced diet and avoid overly restrictive diets. You know, everybody wants to be able to control sort of pancreatitis recurrence or episodes. And so it can be very tempting, I think, especially with the younger kids, to try to like go do super low fat diets or be super extremely healthy to try to prevent episodes. But it's not really clear that this works, and it really can be, I think, not good for children. So we generally just encourage age-appropriate, balanced, sort of healthy diets, but try not to have really fat-restricted diets for kids with acute recurrent and chronic pancreatitis. And then, you know, we really think about pain management and mental health care as a really critical part of what we do. And I think Dr. Armfeld's going to talk more about this as well. But certainly for our program, it's both providing care to the patient, but also thinking about the stress and burden on the parents and caregivers and other family members. It's particularly interesting with the genetic mutations. It's often almost always, I think, we're diagnosing the kids with these genetic conditions, and the parents didn't necessarily know about it. That's changing a little bit, but again, it's usually the kids that are sort of the index case. And there's not that many autosomal dominant issues that we treat in kids, but PRES1 is one of them. And so this can be extremely stressful for a family, I think, having it come from one parent or one side of the family and not the other. And so just to say that we think a lot about quality of life and just mental health care, not just for the patient, but for the other people that are affected by this. And our aims really include preserving their functioning and their quality of life and avoiding opioid dependence. We do use ERCP in pediatric acute, recurrent, and chronic pancreatitis. It can be a really helpful therapeutic tool in some children. From the INSPIRE cohort, we know that about 40% of children that have either chronic pancreatitis or acute recurrent pancreatitis have had an ERCP. That kids with chronic pancreatitis or those with obstructive factors like pancreas divissum or a history of gallstones are more likely to have had an ERCP. But only about 20% of centers that have pediatric gastroenterology can currently offer ERCP. And so it's not something that's necessarily available at all centers. And I think something we're really still trying to figure out what's the right indications and the right frequency to be using this as a therapeutic option in kids with acute, recurrent, and chronic pancreatitis. But I think also important, if it's something you're thinking about as a treatment option, to really make sure that it's happening at a center where they have experience doing pancreatic ERCPs on kids with these diagnoses. In the INSPIRE cohort, when you ask the physicians, about half of kids who had ERCPs, the physician felt that the ERCP was effectively therapeutic, that it helped with pain or reduced hospitalizations. And again, this is a little bit subjective, and we don't really have actually great patient-centered outcomes or patient-reported outcomes on this, but something will be important to think about. This is again from the INSPIRE cohort, what kind of interventions kids are getting when they're getting ERCP. Biliary sphincterotomy, pancreatic sphincterotomy, stent placement are the most common. And you can see that in about half of each of these interventions, folks felt like it was helpful. Pancreatic stone removal happening less often, maybe because they occur less often in kids, but they definitely can occur. And a lot of folks felt like this was, or at least folks that had it done felt that it was helpful when done. So I think it's something that we're still, learning about when and how often, but it really can be a helpful tool in kids that are having a lot of pain or recurrent episodes, if they have some underlying thing like strictures or stones that can be treated. Complications of ERCP in kids are the same that we see in adults. This is from a systematic review of and meta-analysis of ERCPs in kids from a number of different studies that were all retrospective. And post-ERCP pancreatitis was reported in about 5%, with much less common infection and bleeding. So again, in the in the sort of experienced hands or experienced centers, there is not a high risk of complications, but I think that a lot of kids, especially after pancreatic ERCP, do have pain temporarily after the ERCP, and then we monitor closely for other problems as well. We tend to admit all of these kids overnight. I don't know actually if that's the practice at all centers, but we do, especially in the setting of acute, recurrent, and chronic pancreatitis, because we want to make sure they have appropriate pain management and hydration if they do get pain. I think this is a controversial question that we don't know the exact right answer to, but that we think about a lot. Whether ERCP is really needed in a child if MRCP is normal. This is a relatively recent retrospective review of patients from Cincinnati, I believe, Cincinnati Children's Hospital. And they found that the sensitivity of MRCP was decent to pick up problems in kids with acute recurrent or chronic pancreatitis, but it wasn't perfect, especially in those kids who have pancreatic ductal stones. So I will say that, and again, and Cheryl, you may comment otherwise, I don't know what your practice is, but in our practice, if we have a kid that really has clear acute recurrent or chronic pancreatitis, we will often do at least one ERCP or actually use EUS endoscopic ultrasound to help us decide if there's strictures or stones that we might otherwise be missing, to try to see if we can mitigate the symptoms. Again, because there are not that many options, it would be great to have better imaging. Again, I think the endoscopic ultrasound has helped us sort of minimize complications, but still make sure we're doing what we can to help these kids who are really suffering a lot. Even in the setting of an MRCP that doesn't clearly show strictures or stones. It's not something to do sort of over and over again if you've done once and didn't find anything therapeutic to do, but I think something that we think about and that we'll often do once to, again, make sure that we're doing everything we can to help these kids. I'm going to mention this just briefly. Again, I think Dr. Armfeld is going to talk more about pain management, but we did look at opioid use in kids with acute recurrent and chronic pancreatitis in the INSPIRE cohort. And we found that actually almost 1 in 5 reported daily or weekly opioid use. And really interestingly, actually, this did have both patient-reported medication use and physician-reported medication use. So this is all in kids and adolescents. So we're probably, I think we tend to have a little more oversight than in the adult population. And even then, actually, the physicians did not know all the times that their patients were taking either daily or weekly opioids. And there's definitely, I think we saw regional variation. So this is something that families are very aware of. The kids actually are even aware of and are nervous about becoming more opioid dependent. But I think somewhere where we using multidisciplinary pain management have a lot of progress to be made as well. This disease presents a lot of challenges for patients and families and providers, including a lifelong burden with a disease that we really can't cure, except if you trade it for a different disease, which we'll talk a little bit about. The risk of exocrine failure, endocrine failure, and for the PRES1 patients, we worry about their lifelong risk of pancreatic cancer, although it's not something that has been reported in at least the pediatric population to my knowledge. I talked a little bit about what, different reasons that it can be stressful or traumatic for kids and families. And so a really important part of our program, and I hope many programs across the country, is really being on the lookout for when kids are starting to develop more chronic pain picture, and doing what we can to enlist help from mental health support, pain management, genetic counseling, and folks like child life specialists who are really trained to help kids be prepared for procedures and hospitalizations. I'm going to go through this a little bit quickly because I don't want to take up too much time. But we do, if we've done everything we can in terms of medical and endoscopic management, then we do think about total pancreatectomy with islet auto transplant in pediatric patients. As you most likely know, it's a really big surgery. The surgeon takes out your pancreas, takes out part of the duodenum. The kids get a splenectomy, so we do immunize them extra beforehand, and your gallbladder comes out as well. And then the pancreas is sent to the lab for us. That's just in another building quite nearby. The islets are isolated and then infused back into the portal vein with the intent of letting them live in the liver. This is a little bit of outcomes from TPIT at UCSF. It's not something that's available at all centers, but There are a handful of centers, including some you have represented here today, like Nationwide Children's in Minnesota, that also offer TPIT to kids. For us at UCSF, our median age at TPIT is about 13. Almost all of them have some sort of hereditary pancreatitis, some sort of identified genetic mutation where we know this is likely to go on for a long time. The goal is to, get enough islets that they will not be insulin dependent over time. And the sort of number that Melina and colleagues have reported, and she may have updates on this as well, is, ideally we would like to have more than 5,000 islet equivalents per kilo to really improve kids' chances of not being insulin dependent over time. At our center, kids spend about 2 to 3 weeks in the hospital, and they really do very well. If we have a very careful sort of evaluation and selection process to find the right kids. But at least in our experience, kids come off of opioids. I think that's also in the pediatric population because we have a lot of ongoing contact and control over their sort of prescriptions and who they're going to see. They have less ER visits and less hospitalizations. So just to finish up, back to our 9-year-old with chronic pancreatitis, she did have at age 11 a TPIT with splenectomy, and they all get GJ tubes placed at the time of TPIT. This is temporary, usually about 6 months, sometimes less for kids, mostly because they have pretty significant gastroparesis that seems to develop. And so the GJ tubes allows us to restart feeds and avoid TPN after TPIT. And usually that's within the first 3-4 days after the surgery. She had a good islet yield. She was hospitalized for just under 3 weeks. Initially had an insulin pump and continuous glucose monitor. She came off opioids. She came off of GJ foods. She went GJ feeds. She went back to school and then came off insulin. So this is the ideal, obviously. But it is a trajectory that we see in a lot of kids for whom this is the right treatment, which again is not all kids, but in really severe cases can be very helpful. And I think I'll stop there.
All right, thanks, Emily. I don't have any questions in the chat. I just wanted, we don't have a lot of time either, but I wanted to get back to one thing with you. Autoimmune pancreatitis. This for me is, I don't know how to make this diagnosis. And I saw a recent review that actually, instead of just type 1 and type 2, they had type 1, type 2, and pediatric. And to me, that really seemed like that's probably the way we're going, because whenever I've seen the diagnosis made by others, it doesn't really seem to fit necessarily with what type 1 and type 2 are described in adults. Do you have any comments on that?
No, I share your difficulty. I think it's so hard and complicated. And I find that the diagnostic criteria extremely unsatisfying, right? Because like one of the diagnostic criteria, at least for the sort of overall autoimmune pancreatitis, is whether their inflammation responds to steroids. But lots of inflammation response to steroids, not just autoimmune inflammation. And we look for sort of diffuse edema of the pancreas, and we have seen a couple of kids who have that like classic obstructive jaundice because of edema in the head of the pancreas. And so we tend to, I think, try like think of them as potentially autoimmune pancreatitis, but we're sort of like reinforcing our own patterns, I think, currently with that diagnosis. And I don't know, like it would be nice to have better markers.
Yes, definitely an area where we need to go do a lot of work on that one.
Yeah.
Vic, you want to do the next introduction?
Yeah, absolutely. So our next speaker is Dr. Matthew Armfield. He is an assistant professor at the University of Minnesota in the division of pediatric gastroenterology. And he's going to be talking to us about non-pharmacologic approaches to pain management in pancreatitis. Dr. Armfield.
Thank you very much. Get my screen up. Are the slides showing?
Yes.
Okay, great. So I'm going to talk about non-pharmacological approaches and really focusing on the TPATE surgery. So prehab prevents persistent post-surgical pancreatectomy pain in pediatric patients. I'm Dr. Matthew Armfield. I'm a pediatric pain doctor. I also like the pancreas. I do wear fun t-shirts at work, and I love dad jokes. So I have got nothing to disclose. Today, we'll talk about the pathophysiology of chronic pancreatitis and its consequences, which has already been covered, so I'm going to fly through that pretty quickly. Then evaluate the components of a successful pediatric pre- and post-surgical pain prevention and treatment program, and then also recognizing barriers in appropriate chronic pain treatment in children and adolescents. So to do this, I have a set of 4 patients which I would like to talk about. And so first one is Elizabeth. She is a 13-year-old who has been living in pain for as long as she can remember. She has seen countless doctors to help explain and treat her constant stabbing abdominal pain, but none of them could ever figure out what's wrong until an ED physician finally drew an amylase and lipase and subsequently diagnosed her with pancreatitis 2 years ago. She now rates her abdominal pain as 7 out of 10 on a good day and needs multiple doses of hydromorphone throughout the day so she can be minimally active. She disenrolled from school 3 months ago due to the number of absences she's acquired and now is completely homebound tutoring for her school. She has significant medical PTSD and anxiety from the many medical providers who didn't believe that she was really in pain. So that's Elizabeth. Next is Jackson. He is a 16-year-old who was pretty much pain-free until about 2 years ago when he was diagnosed with pancreatitis after his first episode of severe abdominal pain. He's established with the gastroenterologist at the local children's hospital and has learned how to manage many of his severe symptoms at home, so he's not hospitalized frequently. Despite him describing pain as a constant, sharp, burning 7 out of 10 pain, he's relatively active at baseline, even making the JV basketball team last year. He still attends school in person and works at a job 3 days a week. He has significant anxiety and working with a psychiatrist to keep that under control. He does not routinely take analgesic medications. So in both Elizabeth and Jackson, there's a specific nociceptor that is the cause of their pain, the pancreas. So it follows that if you remove the nociceptor, the nociceptee's pain will get better. The problem is the nociceptor, the pancreas, is a pretty important organ, as you guys know. Removing it will also remove their ability to produce insulin and digestive enzymes. So what if there's a way to remove the nociceptive input while preserving its endocrine insulin-producing function? So you can skip through the anatomy. Incidence, recent studies have shown an increasing incidence of pediatric acute and chronic pancreatitis over the last 2 decades. What both studies suggest here, that is the increasing awareness of pediatric pancreatitis among pediatric care providers and subsequent increase in biochemical testing for pancreatitis is largely responsible for this increase. And which was already discussed, the risk factors of pancreatitis in the pediatric population, the most common is genetic. In fact, these 2 genetic mutations, PRSS1 and CTRC, also carry an increased risk of pediatric cancer later in life. Therefore, pancreatectomy will also eliminate this cancer risk. The other most common cause of pancreatitis in children and adolescents is idiopathic. Other less common risk factors include obstruction, toxic metabolic, and autoimmune. Acute pancreatitis causes inflammation and ischemia necrosis, which generates a significant amount of nociceptive, what I like to call, talk to the patient, what I tell the patients, tissue damage pain. Or nociceptive pain is the fancy term for that. Repeated episodes of pancreatitis, which usually they're pain-free in between episodes, starts to sensitize their peripheral nerves, causing more neuropathic or nerve-type pain. Eventually, the pancreas itself undergoes permanent structural and physiological changes, and usually by this time, the patient has been centrally sensitized and experiencing pain in the absence of nociceptive input. And so even if their pancreas is not inflamed, their brain is interpreting pain signals from their pancreatitis, from the pancreas, and any signals coming from the pancreatitis as pain. So the brain is interpreting non-painful inputs to be painful. That's called allodynia. And then already painful stimuli can be extremely painful, even that much more painful. It's called hyperalgesia. So the combination of allodynia and hyperalgesia is central sensitization. Really, you can think about it as pain outside, patient experiencing pain outside of nociceptive or tissue damage or inflammation. So, like was mentioned, management, medical therapies include treatment of endo or exocrine insufficiency, fat-soluble vitamins, and pain medications. Endoscopic therapies include ERCP for sphincterotomy, biliary or pancreatic duct stenting of strictures or stone removal. Surgical therapy can include cholecystectomy, drainage procedures, or what we're going to talk about is the TPATE procedure. And so this is a total pancreatectomy with auto transplant. The total pancreatectomy is to relieve pain and improve the quality of life, whereas the auto transplant is to prevent or minimize post-surgical diabetes. So getting a little bit more into the how that procedure is done. First, the pancreas is removed. You can see right there. Second, it undergoes both enzymatic and mechanical digestion. And then the islet cells are infused back into the patient via the portal vein, where they set up shop in the liver, and then your liver basically becomes the pancreas, well, half of the pancreas job. So initial findings with focus on pain and opioid use. The initial findings were mixed. Out of 24 patients in the study that Dr. Bellin looked at, 2.5 years after the TPATE procedure, 18 patients had follow-up, 6 lost to follow-up. 11 of those 18, or 60%-ish, were off of opioids at follow-up or at death, whereas 7 patients were chronic opioid users, 5 with using strong opioids like morphine, Dilaudid, fentanyl, oxycodone, whereas 2 were taking weak or mixed opioids such as tramadol, buprenorphine, nalbuphine, medications like those. Then for pain, of those 24 patients, 2.5 years later, 15 patients were followed and asked what their pain level was. 10 of those 24, 10 of those 15, about 67%, had no pain symptoms, whereas 5 had either shown pain improvement or no change in pain. So they were still in pain despite the procedure. Now, when I saw some of this data, and we'll talk about a couple more patients soon, I asked the question, like, why was this procedure successful for some and not others? And so these 2 patients, what I'll talk about next, kind of will help explain the process that I went through to try to figure that out. So first, I'm going to talk about Michaela. She's 16 years old. I met Michaela when I was completing my fellowship at a different institution. After she was diagnosed with hereditary pancreatitis, she started coming to the pediatric chronic pain clinic where I was a fellow. She did remarkably well and was able to regain function almost completely and reduce her pain in between pancreatitis attacks to a manageable level. Luckily, her last acute pancreatitis attack was over 9 months ago. I knew that she was scheduled for a TPATE procedure in about a month, and I told her, based on how well that she did with us in that clinic, I thought that she would fly through the recovery, and she did. 6 months after her TPATE, she was off of opioids, pain-free, and living a seemingly normal life. And finally, there's Jamal, a formerly athletic 17-year-old with hereditary pancreatitis. Jamal was scheduled for a TPATE within the first few weeks of me starting at the University of Minnesota, so I was not involved with his preoperative care. At the time of surgery, he was taking daily opioids, missing a significant amount of school due to pain, and was moderately deconditioned physically. His immediate post-TPATE recovery was uneventful, but he struggled with daily quote-unquote phantom pancreas pain, which you call it, like the pancreas is gone, but they still have the same amount of pain in the exact same spot than they had before. And he was unable to wean off of oxycodone following the surgery. 1 year after TPATE, he was still in a significant amount of pain, still taking opioids and not attending school. So I started thinking, we have these 2 patients, and both of them have hereditary pancreatitis, and both with chronic pain at diagnosis. One patient was able to get her chronic pain under control, and the other was not. So when the respective pancreases were removed, Elizabeth was pain-free, while Jamal still had chronic pain. So obviously it's a little bit more complicated than just the removal of the pancreas. So it becomes important at this point to think about our patient's pain as a complex combination of both nociceptive or tissue damage pain and chronic pain. And therefore, you can't just treat nociceptive pain, nor will just focusing on chronic pain provide long-term relief. You have to treat both. And several orthopedic studies have shown this to be the case. Now, this chronic pain is a level of central sensitization. And so taking a look at central sensitization in different orthopedic studies have shown that treating that after surgery can improve outcomes. This study, Bennett showed that patients with high levels of central sensitization had worse postoperative quality of life outcomes and increased length of stay after spinal fusion surgery. Beck showed that association between catastrophizing and central sensitization and the patient's numerical report of pain. And finally, Brummett, in the last example, found that patients with high fibromyalgia survey scores, which is a proxy for central sensitization, were associated with higher preoperative pain severity, more negative affect, depression, anxiety, increased tendency to catastrophize pain, worse physical function, and more opioid use. So up until this point, this was now 2016 at the time, this is what the process would generally look like. It was pretty conventional. You have surgery, rehab, and resolution. But not all patients would reach resolution. Were these patients whose central sensitization was not adequately treated? I assume that yes, they were. So then how can I tell the difference between those whose sensitization was adequately versus inadequately treated? I either said to myself, I can't, or that's too much work, and decided the multidisciplinary chronic pain approach to prepare patients for surgery, what we call the prehab approach, would be beneficial for every patient instead of trying to figure out who would benefit or who wouldn't. So this is our approach now. It's more than just a surgery, it's actually a journey. And so you have preparation, prehabilitation, TPAPE procedures at the peak of their pain really in the journey, then prehabilitation revisited afterwards, and then you can see progress. So talking about each of those individual steps, for preparation, this occurs at our initial evaluation when I meet with the patient and family for the first time. The first part of my talk is kind of the doctor stuff. You actively listen, you believe and validate, and I try to act bored. And this is to show the patients and family that I've seen this condition before. I know what I'm doing. I say, yeah, you're boring. I tell the patient directly, yeah, you're boring to me because I've seen cases just like you all the time. And so that gives familiarity to their case, where usually they're going into medical centers and many times the physicians have no idea what to do or how to treat these patients. So that's the doctor stuff. Then the most important part, I think, is the teacher stuff. And this is when I give a little pain talk for about 30 minutes at the end of their patient visit. And here's when I teach about pain, what to do about it, to ask them things that they do, know that I'm going to pretty soon ask them to do things that they do not want to do. So even before I start explaining anything, I tell them verbatim, your pain is real. Now, this, when I was in fellowship, my fellowship director said that this is probably one of the most important phrases to say to your patient, because the moment I say that, I have established then trust between the doctor and the patient. And that trust is going to be very, very important to establish, because you're, like I said, you're going to be asking your patient to do stuff that they do not want to do. And so in this point, we're explaining why the treatment plan is as follows. We're going to convince them that it works, and then kind of trick them into themselves coming up with a treatment plan themselves, when really you're guiding them into this this plan themselves. So I do have an example of one patient here. This is listen.
Go to Minnesota, get a second opinion there, and see what happens. So we ended up doing a virtual appointment with them and told them all about my case and everything, and they were like, I mean, I knew within the first 10 minutes of talking to them, they believed me. They didn't doubt me. They said your pain like is real and everything like that validated how I was feeling, which was the most amazing feeling because I hadn't felt like that for years. And when you're in high school and getting told constantly that you're just looking for pain meds and stuff like that, it gets really like overwhelming. So it was just like a breath of fresh air. So I think you should.
Okay, so next after the preparation stage is the prehabilitation stage. And this is preparing an individual in advance to withstand a stressful event through enhancement of functional capacity. And so taking a look at prehabilitation, this study by Robert Top, taking a look at the effect of bed rest and potential of prehabilitation on patients in the ICU. This was an adult study, but you can still get the same takeaways from this. So here at the dotted line here is the patients who went under prehabilitation. The solid line is for no prehabilitation. And so the patients who did the work beforehand, which we're going to talk about soon, they spent less time under an initial level of functional capacity and minimal level of for independence functioning, and returned to an initial level faster than those without prehab. And so these are the things that my patients generally do not want to do because it's hard work. And I tell them that it's exactly that. So to treat physical deconditioning, central sensitization, impaired descending inhibition, high catastrophizing fear of pain, and everything else, they undergo physical therapy, integrative medicine, or mindfulness training, psychology, and the most important is to normalize their life, which is the 4 S's: school, sports, sleep, and social. So they have to go to school. They have to get good sleep. They have to have a social life. I prescribe them to have fun every day. And they need to be active, need to replace sports, which they will generally get under physical therapy. So that's the general overview of the treatment plan. And that's where I focus most of the time in my talk in the preparation stage, saying these are the 4 required parts of the program. Physical therapy, you have to get up and move. Movement is medicine. And so the more physically conditioned your patient is, the more likely they're going to have positive outcomes after the surgery. Integrative medicine, they have to pick at least one non-pharmacologic method or technique to reduce the amount of pain that they are experiencing. And so this would be things such as deep breathing, guided imagery, self-hypnosis, biofeedback. Those are all the active mindfulness techniques that they can use. Other more passive ones would be things like massage, chiropractic. That's someone's doing something to the patient rather than them doing it themselves, which can be useful, but we found that the more effective approaches are more active mindfulness techniques. All of my patients have to see a psychologist because more pain causes more stress causes more pain, more stress, more pain. And this is a vicious cycle. And so in order to get pain under control, you really have to treat the underlying anxiety and depression that is present in almost all of our patients. And then finally, they have to normalize their life to teach their brain that the world on the outside and school and such the really, really important things are not dangerous places that their brain needs to protect them from. And in order to protect patients from those dangerous scenarios, the brain causes pain. And so once you normalize your life and get back going to school, playing sports, being social and getting good sleep, slowly you will get their brain to realize that those normal functions are not dangerous and their level of chronic pain will hopefully go down. The 5th and only optional part of a program is medication management. And most of the time that our patients are coming in at this point in their journey through with chronic pancreatitis, most of them are going to require a couple of 1 or 2 chronic daily pain medications, but not always. So in order to do all of that work, you really have to assemble your team. You can't do this alone. And so if you have a pain physician or nurse practitioner, that's important, physical therapists, psychologists, integrated medicine specialists, and then a whole list of other different providers on the team that can help you with those goals. So taking a look at several studies of preoperative physiotherapy, several studies have shown positive outcomes such as reduction in complications after intra-abdominal, pulmonary, and cardiac surgery as a result of preoperative physical therapy. Similar to preoperative physical therapy, preoperative psychotherapy might be beneficial for individuals undergoing several different types of surgeries. These studies have shown that psychological preparation may be beneficial for outcomes, including postoperative pain, behavioral recovery, negative affect, and length of stay, and is unlikely to be harmful. However, further evidence and more studies are going to be needed. So after the preparation and after the prehab approach, they undergo the surgery. And at this point, in the initial preparation, I do tell them that their pain will get worse before it gets better, because I don't want to hide anything from them. I don't want to trick them. And I want to be honest with them that it's going to be a very, very painful procedure. So this is where the majority of the drugs come in. Pre-op, at our center, we always do a paravertebral nerve block, and that's usually kept in for 7 days. And that has shown to reduce length of stay and reduce postoperative pain. After the surgery, they're going to the intensive care unit, and this is where I just throw everything but the kitchen sink at them. They're on an opioid infusion plus PRNs. They're on Presidex, IV Tylenol, IV Toradol, gabapentin, usually a antidepressant or a tricyclic antidepressant. Sometimes benzo and ketamine can also be used. So really everything that's in your arsenal, we throw at them to help them get up and able to function as quickly as they can. When they hit the general floor, after about a week in the ICU, that's where I taper their opioids, switch to oral medications if possible. And then as an outpatient, I continue tapering their opioids and adjust other medications as necessary to maintain function. Usually I like to keep patients on gabapentin for about 3 to 6 months after the surgery, based on the amount of other medications that they're using at that time, such as Tylenol for pain control. So the fourth step, and this is what most people realize as the actual rehabilitation part, or as I call it, prehabilitation revisited, because it's the exact same thing that they did before, but it takes less hard work because now they've already done it once. They've already reduced their pain once before. And so now they just have to do the exact same stuff that they already had gone through. And so the second time around, it becomes that much easier because they're familiar with it. And I've stressed, they know and they can see the importance of these techniques, these non-medicine techniques in their recovery. And that's when we see progress. And so when I mentioned Jackson before, this is just a stock photo of him. This is not actually Jackson, but this is actually Jackson. And I want to play, here actually his name is Seth. I'll play a little bit of what he's had to say about the whole approach.
Surgery complications, if I can even call it complications, this come from diabetes. The pain relief was pretty immediate, which was astonishing, honestly. Yeah, I've been thinking this whole time, I can't think of really a single time I've had any pain, like even abdomen pain really at all, since the surgery. You know, I was I'm living out with a buddy now at Mississippi. I'm living off campus. You know, so I get to provide for myself in ways that I've never been able to, and this was only really made possible because of this procedure. So surgery.
And then finally, with Elizabeth, her actual name is Karis. This is again not her. This is a stock photo I have. This is Elizabeth or Karis, and I didn't have a video clip of her talking about the procedure, but I texted her mother a while back, and she said that she's doing really well. She's full of sass, knows everything, and is never wrong in typical teenage style. She's been doing all the typical senior things that seniors do. She's working on an average of 20 hours a week, going to school and spending lots of times with friends. She laughs a lot and loves to share her story with anyone who's interested. She has bouts with residual pain here and there and has had a couple of trips to the ER this year, but no stays overnight. And she's handling the news of, quote, nothing is wrong, unquote, much better than in the past. We've got our girl back in an even better version than we could have ever imagined. Thank you very much.
Thank you, Dr. Armfield. In the interest of time, maybe we can do one question. Cheryl asked a question stating that Michaela had her pain under control prior to the TPIT. So since the indication for TPIT is pain and poor quality of life, do you have patients that no longer need a TPIT after the prehabilitation?
No. Usually at that point, their level of pain is such that even if they get their pain under control, they're still going to have episodes of acute pancreatitis, which causes significant pain, and it just gets that much harder to control the chronic pain that they experience in between those episodes. So generally, if we can get them to the point where they're pretty much pain-free in between episodes of acute pancreatitis, you're in the golden spot where they can generally pretty much do very, very well after the surgery.
And to what extent are you trying to use neuromodulators to potentially avoid the use of opioids? You know, that's become an area of real focus and attention in the adult population. You know, I do this a fair bit, and I have really been trying to escalate the neuromodulation in an effort to get patients practically off of opioids before TPIT. And one thing we do know is that patients who are on gabapentinoid drugs also require less opioids in the perioperative and postoperative period. So what have been your experiences in the pediatric TPIT population with regards to that?
It is probably one of the most common drugs that I use in this population and my chronic pain population as a whole. If they're experiencing pain on a daily basis or significant pain in between acute pancreatitis episodes, I will generally start them on gabapentin if they're not on it already. Once the surgery hits, every one of my patients gets started on either gabapentin, or if they're on that and didn't work, pregabalin or Lyrica. And those medications are continued, like I said, about 6 months, on average, about 6 months after the surgery, depending on the level of pain. If they're doing really well, I can stop it at 3. Sometimes it lasts longer and up to a year plus, depending on how they're doing. But it's a staple in our treatment.
Thank you. I appreciate it. I think with that, we probably can wrap up. I don't know if, do you have any comments, Melina, or?
No, I just wanted to say again, thank you everyone for attending. All of the webinars are available online on the CAPER website. So if you missed a topic you want to go back and see, it is there for viewing. And again, we thank you in advance for giving us feedback. We'd love to tailor these sessions next year towards what people want to hear more of. So, and thank you to our speakers and moderators tonight, and everyone have a good evening.
Good night, everybody.